Hello, everyone. Welcome to our session today. Today we have Dr. Sandy Goodman from RMG that will be talking to us all about transfer cycles. Before we get started, I'd like to go over some kind of housekeeping rules. We have a Q&A box on your panel. Please go ahead and put any questions that you have during the session in the box, and Dr. Goodman will be able to answer that for you at the very end. If you're unable to watch the whole session or would like to share this with your colleagues, you will receive a recording of the session within 24 hours. And you can certainly share that with your friends, with your colleagues, with the providers at your practice as well. And without much further ado, I'll hand it over to Dr. Goodman.
Hi, I'm Dr. Sandy Goodman from the Reproductive Medicine Group in sunny Tampa, Florida, and I'm so happy that you could join us today for this session. I hope that it will be very informative for you. I'd like to today focus on the embryo transfer procedure, that which leads up to it, the procedure itself, and the ASRM guidelines. I want to help your practice find the balance between experience and expertise, which is always important, versus, or maybe in accordance to as well, evidence-based techniques. So just to start with, as many of you know, especially on the clinical end, there are so many variations in practice. And in fact, there can be variations even among the physicians in your group. And it's always that balancing act when the patients are asking questions as to why something is being done. So even prior to getting to our transfer, which we're going to focus on, stimulation protocols, such as what type of down regulation your patients may be receiving. Are they getting a flare protocol for their protocol, a luteal phase, a antagonist protocol? What medications or combination of medications are they using? Are they using adjuncts like growth hormone and DHEA? And when are they going to be triggered? The timing, the follicle size, the estrogen level. Are they going to be getting a Lupron trigger, an HCG trigger? So a lot of this is going to be based on the patient's parameters, what their testing has been beforehand in terms of their egg health, but it's also going to potentially be regulated by the physician's experience. This patient in this scenario does better with a particular protocol. And so that can be a little bit difficult because that means the patient could be starting their downregulation during their luteal phase, or they may be starting a pill with their period. And obviously, it's important for us to be able to help our patients understand their protocols. And a lot of that is going to be on the experience and expertise of the physician. Similarly, for retrievals, we'll see centers with various types of anesthesia. I've heard of practices where there's no sedation or IV sedation, and others where there's very significant sedation. And what type of prep when you're in the OR? Does somebody use betadine or saline, or what they might use? So these are variations just in every aspect of our cycle for our patients. But today, what we're going to do is focus on the transfer. What we do prior to the transfer in terms of evaluating the uterus. Are we doing a fresh versus a frozen transfer? What type of preparation we're doing for the lining, and then what we're doing pre-procedure, leading up, or on the day of the procedure, and then post-procedure. So let's dive into that now. Okay, so pre-transfer, again, this can vary from clinic to clinic and sometimes even doctor to doctor. But in terms of pre-transfer, whether we're doing a fresh or a frozen, many clinics will use a saline sono to assess the uterine cavity and potentially at that same time do a mock or trial transfer to determine where the catheter should go. Is it an easy or difficult transfer? Other clinics will routinely do a hysteroscopy, but the key is to make sure that the uterine cavity is normal before we're going to take our precious embryo and transfer it, and also that we're not going to encounter significant difficulty due to either the way that the uterine cavity meets up with the cervical canal or problems with the cervical canal. So we do those pre-transfer, and that's going to vary from clinic to clinic, but to assess and make sure that everything is normal within the uterine cavity is done by most clinics, and that's important. Fresh embryo transfer. Now, interestingly, as of 2020, more than 80% of transfers are frozen embryo transfers. So for many of you, that will be the bulk of the patients that you are working with are going to be having a frozen transfer. But just to back up with a fresh transfer, we might be using vaginal progesterone versus intramuscular progesterone. Some clinics will adjunct with estradiol. And what we know is on a fresh transfer, the optimal endometrial stripe thickness is going to be in that 10 to 12 millimeter range. So that's our minimum. And there are maximums as well in some studies, but overall, we're hoping that we're going to have that endometrial stripe thickness to support the embryo. Frozen embryo transfer, as I just mentioned, is more than 80% of the transfers to currently. And so this is where I want to spend more of my time with you today. So before we lead into the transfer, the actual procedure, there's going to be some type of prep, whether it be by a natural cycle or with medication. So we divide up how we prepare the lining to go into the transfer to natural, which means LH kit, we're not going to add anything else. We're depending on the corpus luteum to produce the progesterone to get that lining ready. There is likely going to be ovulation occurring in order to be able to use that natural cycle, because the estrogen being made by the developing follicle will get the lining ready, and then there will be an ovulation, and the corpus luteum will be then present to provide progesterone. Now, modified natural cycle is more common than natural, where we're going to maybe use sono guidance, sono to let us look at the development of the lining, let us look at the development of the follicle, and then we're going to have possibly HCG trigger injection, and then possibly progesterone support in the second half of the cycle. The program cycle, which I think is more common, I would say significantly more common, and of course you're going to look at your own practices to see, but this is where we're going to use some form of estrogen and progesterone to create a lining in the uterus. And that estrogen is going to vary from clinic to clinic, and maybe even from doctor to doctor, and maybe even from patient to patient. It can be oral estrogen, a patch of estrogen, intramuscular, which is called del-estrogen, and in some cases even vaginal estrogen suppositories. And we're going to generally do a couple, actually sometimes less monitoring in terms of sonos, just to look at that lining and make sure it's responded appropriately, and then initiate progesterone by either oil or vaginal. And this is going to vary from practice to practice as well. In these instances, you're going to see that our optimal thickness is going to be a multi-layer lining that's at least 7 to 10 millimeters. Now, some patients will get caught up on that and say, oh, my lining should be 10. I read somewhere, or more likely I got on a blog somewhere, spoke with my group somewhere, that 10 millimeters was important, but that's actually not what the literature shows. The literature shows 7 millimeters is or above is optimal, and there have been a few studies that look at lower pregnancy rates if we get much above 14. So I think if we were at 14.5, that's not a problem, but when we start to get into linings that might be exceeding that 14 mark, maybe 15, 16, 18, that might cause an issue with implantation. And there are studies to show that there is some diminishment in the live birth rate when the lining is less than 7 millimeters, and an even greater reduction if it's less than 6 millimeters. That said, we'll all have our anecdotes where somebody had a very suboptimal lining, they wanted to do their transfer after multiple different tries, and they decided to go through it, got pregnant, and had a healthy pregnancy. So these are reduction in success rates rather than absent success rates, not all or none, but we're shooting for at least a 7 millimeter, 8 millimeter, 9 millimeter, 10 millimeter. Those are going to be our sweet spots. Now, the question then becomes, after we prepare the lining, among different practices, and the American Society for Reproductive Medicine has actually given us an outline at this point as to what do we do on as far as adjuvants go on the day of transfer, and procedures. So we're going to spend a little bit of time talking about that next, but what type of gloves do we use, and do we use acupuncture, massage, antibiotics, sono guidance, removal of the cervical mucus, the type of catheter, how fast does the doctor inject? Do we leave the catheter in or take it out immediately? What happens if there's retained embryos? And what happens after the procedure? Because our patients often feel worried about getting up, moving around, and that can lead to a lot of angst. And it's important for all of us to be able to be armed with the correct information so we can share that with our patients and reassure them. So that's very important. Okay, so let's go ahead and move on to the next slide and take a look. Okay. So just to circle back to the natural versus programmed FET cycles, because this has gone online. A lot of my patients have been asking and insisting on the natural versus the programmed. And a lot of times this comes up because there will be a paper or something that comes up that suddenly the groups online have chimed in and decided, what the flavor of the day is. So let's just get into that because you might have some of those questions. So same live birth rate in natural and programmed. We just have found that in some studies, progesterone in oil may be better for the live birth rate if we're doing a programmed cycle. But it's interesting because I've had patients come in and say, oh, I've heard that live birth rate is better, is superior, and the live with the natural cycle, excuse me, but in fact, that's not correct. Now, the natural cycle may have a little bit higher of cost because there's actually can sometimes be increased monitoring to make sure that the patient is actually developing the follicle and reaching a peak. And so sometimes that actually can be more costly, and that's been looked at in a paper that's the case. And the timing can be much more challenging for a natural cycle, both for the clinic and the patient, because we just don't know when the follicle is going to be released. And so that can make it much more challenging. There have been some papers that have looked at a higher incidence of pregnancy-induced hypertension in programmed cycles, but part of that, and when we read the papers and when our patients hear this information, they're not actually understanding sometimes the full picture, and that is that PCOS and anovulation patients who often will have other underlying health issues, which can include weight issues, a propensity towards hypertension, even if it hasn't yet been manifest. Those patients generally are going to do programmed cycles because they can't LH track to pick up the ovulation because they're not ovulating. So we're going to have more programmed cycles having those patient types. And so that is going to affect sometimes this later incidence, which may really be due to the patient selection rather than having a programmed cycle way back when the embryo is transferred. So that's kind of an important thing. And it's very important because, again, when the patients go online, they're gleaning this information, but they're not necessarily reading the original paper to be able to have that chance, nor do they have maybe the medical understanding to be able to discern, oh, here's the problem with that paper. And that's why that becomes incumbent on you to be educated and understand what they're reading may not be the full picture. And then you have the confidence to be able to say, actually, that's not the case. So, All right. So let's go to the ASRM Practice Committee guidelines on embryo transfer, and probably because, as I mentioned, more than 80% is frozen on frozen embryo transfer guidelines. And so what ASRM did several years ago is they actually went to the members, the physician members, and said, you know, what do you do? And then let's go and do a literature review to see what has papers that have been studied on these practices and what they've shown. And interestingly, there's a lot of areas where there's not a study done or good studies done, and that leaves a lot of room for our Inception Network to maybe do some of these studies so we can bring better light to what should and shouldn't be done and to give better guidelines. Because when we do things with evidence base, that helps us to make the best decisions for our patients. So there is a wide variation, and as I mentioned, there are limitations. So there have been some meta-analyses done. That's where they take a lot of studies that are out there and put them all together, decide which ones are valid and valuable in terms of their techniques that they've used, and then put them together to try to come up with an answer. And so we're going to break that down into the pre-embryo transfer, the procedures and techniques, and then the post-transfer. So go to the next slide. Okay, so what did they look at for these particular guidelines? Well, they looked at acupuncture, they looked at massage, they looked at the use of analgesics, and they looked at prophylactic antibiotics as things that are done pre-procedure. Oh, can you go back? Oh, no. Sorry. Okay, so acupuncture, multiple randomized controlled trials, contradictory results. We see some that show help, some that don't show help. Ultimately, for meta-analysis, no difference in the pregnancy rate or live birth rate with or without acupuncture. And there's pretty good evidence to say that. So does acupuncture hurt? No, maybe it's going to relax the patient and that's going to make their experience better. So that's all good. There was one study that showed lower pregnancy rates when the acupuncture was done immediately after the transfer. And so I generally don't have my patients continue with acupuncture post-transfer. But again, that was one study. So we can't ever rely, unless it's a humongous study with great technique, on one study. But since there's no evidence to show help, I feel that if my patients want to do it beforehand, I can inform them that there's nothing to say that it's going to help, but if it makes you feel better and more relaxed, absolutely. And maybe post-transfer, let's hold on that. Massage, very soothing, it's wonderful. I know lots of people who love it, but there's no evidence to show that it helps. Does that mean we shouldn't do massage? No, they can go for it, but it's not that there's any evidence, except for if it makes them feel better and makes the process better for them, that's not a problem. Use of analgesics. Now, some people feel worried, the patient's gonna have pain, that might cause uterine cramping, so we should use analgesics to help with that. Well, there were not any relevant studies that demonstrated a benefit from analgesics, but I will tell you that it's 50-50 when physicians were polled, 50-50 as to whether they use a relaxant prior to the transfer. 46% said yes, 54% said no. In our practice, we do use Valium, and on a personal, and again, experience versus what actually is shown in the studies, I find my patients are much more relaxed, and therefore it's easier for me to use the transfer catheter, place the transfer catheter, because their muscles are more relaxed. But the reality is that it does not change the outcome. So it might make it easier on me, but it doesn't change the overall outcome, and that's okay. So there's no problem with using Valium that way. It's just to understand that, concept of, let's say, uterine contractions, that's actually not actually going to be a true thing. Prophylactic antibiotics. Lots of people use prophylactic antibiotics. For years and years, we did it at the reproductive medicine group. We've dropped that. But prophylactic antibiotics, specifically looking at Augmentin for fresh transfer, and then more recently, doxycycline, did not improve live birth rates. So we don't have any evidence to say that routine use, and we've dropped it, routine use of prophylactic antibiotics has a role in the embryo transfer process. Next slide. Glove type. So there was small, because there's just not a lot of studies on this, single randomized controlled trial, no difference in pregnancy rates if we use powder versus non-powder. That's important because a lot of times we worry about whether powder could cause a problem. But again, we're not touching the embryo, we're touching the catheter, we're not usually touching the end of the catheter. There was no studies that assessed the type of usage of glove type, but ASRM has recommended to use sterile gloves. And in fact, that's the case for almost all of the physicians that that most will use sterile gloves as part of the transfer process. So that's interesting. And I think that there's reasonable evidence to say, of course, you want to use technique that's going to keep things as sterile as possible. Abdominal sono guidance, 35 randomized controlled trials, pretty much all of them showed that there is a improved clinical pregnancy rate and live birth rate using sono guidance during embryo transfer, and that had a grade A, which is the highest grade. So when physicians were questioned, 93% always used ultrasound guidance, and I think that we need to probably push that up to 100% because that actually does have really good evidence base that we should be doing that. Catheter type. Any soft pass catheter has a higher pregnancy rate than firm catheters, and pretty much all physicians now do use soft catheters, whether it's going to be a different brand or not. They did not see a difference, that there was not a particular brand that was better than another for the soft catheters. So I think that definitely would be physician preference, and I think that's pretty much around the country. Okay, next slide. Embryo transfer position. Now, for some of you, this is a little above and beyond because you're not doing the transfer. This is really more physician-based, but it is interesting because sometimes, we have different, we still want to know because we have different input from our patients, might be asking questions. Because there's sono guidance, they can see things. So, what is the best? And the best is, in fact, to place the embryo in the upper 2/3 of the uterine cavity, at least 1 centimeter below the fundus. So that's kind of critical. All of the studies that were really pushing the information out said, agreed, at least 1 centimeter below the fundus. And I think that when physicians were questioned, 66% said they put the catheter tip in the upper third, and 29% the middle third, and that would be the right answer. So only 5% were the lower third, that would be the wrong answer. And then 1 to 2 centimeters, most were 1 to 1.5 centimeters below the fundus, and so that is the optimal place. Velocity of the injection, there really wasn't any data to say that injecting slowly is any different than injecting quickly. So I think that's something that could be looked at, simply because there would be, from my end, from the physician end, if I inject too quickly, could I push the embryo up and cause a ectopic pregnancy or something like that? But there isn't any data to help guide the physicians on that right now. So that might be a good study for us at Inception Prelude. Transfer catheter withdrawal time. So this is interesting because there is a difference in opinion, and basically the ASRM guidelines have said that we should remove the catheter immediately, not delay. And when they questioned physicians, 31% removed immediately, and 33% delayed 5 to 10 seconds. And ASRM has recommended immediate withdrawal of the catheter, not to delay it. So we're not leaving the catheter in there for, counting to 5 and then taking it out. Now, that doesn't mean we couldn't count 1, 2, just to make sure we've got the embryo out. We've pushed the last amount in, but then there's no evidence to suggest that leaving it in longer is helpful. And then one other topic that is can cause a lot of angst, whether it's to the physician or the patient or the embryologist, is, does a retained embryo that has to be reinserted, the catheter has to be reinserted, does that affect the clinical pregnancy rate or miscarriage rate? So generally, when the catheter is withdrawn from the cervix, the embryologist takes the catheter back and flushes it with a small amount of fluid to be sure that the embryo, in fact, was released from the catheter. And if not, then they will reload the catheter. And what was great to know is that there was no effect on the clinical pregnancy rate or pregnancy loss rate. So that is nice for all of the staff to know that there is no detriment to the patient in terms of getting pregnant if the catheter has to be reinserted. Okay, next slide. So this is a big one, and get asked this all the time. Staff gets asked this all the time. A great cause of angst for the patient. So for when I started out in my career, the patient had to be on the bed with using a bedpan for at least 2 or 3 hours before, believe this or not, before they could get up after the transfer. So it was felt super important to be not even get off the transfer table for a length of time. And then that progressed and it became like, okay, get up to the bedside commode. And then that progressed further. And then finally, we've reached to the point of the patient has the catheter placed, the embryo is discharged. We show that the catheter is clear and we say, okay, time to get up and walk back into the recovery area. So this can cause a lot of anxiety for the patients who feel like their embryo might fall out. And the fact of the matter is it won't. What we explain to our patients at the reproductive medicine group is that the endometrial lining is like a mesh, and the embryo is being placed into that mesh, so it's not moving out of that area. The embryo does float within the mesh, but it's not being expelled out just because somebody stands up or voids or uses the bathroom. So it is very nice to see that the evidence shows that immediate ambulation post-transfer actually benefits the patient, and that there was actually a lower pregnancy rate even if the patient was kept for 10 minutes on bed rest. And one might say that doesn't make sense. Why would 10 minutes on bed rest cause a negative? And there's been some question as to whether it has to do with the way that the uterus is in the cavity, or whether there needs to be more studies to really see if there's a detriment versus no difference. But for certain, there is not a benefit held for having the patients bed rest after a transfer. There isn't a benefit demonstrated that after their transfer, they should go home and be on bed rest for 2 weeks or 10 days or whatever post-transfer. There's nothing to show that at all. Obviously, we're not going to tell our patients to go skydiving or horseback riding per se, but there actually are no studies to suggest that bed rest or limiting ambulation improves our pregnancy rates. So we can reassure our patients that that actually is not at all helpful. And so that is not necessary. Next. So evidence-based conclusions. So where we really have the studies to help us are transabdominal ultrasound guidance for the embryo transfer is helpful, positive, good. Removing the cervical mucus from the cervix is good. And actually, I didn't touch on that one. That is important. So usually you'll see if you're in the transfer room with the physician that we're doing something to remove the cervical mucus. Almost all physicians do, and that is helpful. The cervical mucus, leaving it in place can be a problem. It can lower the success rate. So soft embryo transfer, I think that's pretty uniform at this point, and placing the catheter tip in the upper or middle third of the uterine cavity, at least 1 centimeter to 1.5 centimeters from the fundus to expel the embryo. And that immediate ambulation post-transfer is positive. Okay, now I think we're ready for questions and answers. I just want to thank you for your attention, for participating in this webinar, and look forward to us standardizing things here through the Prelude Network.
Thank you, Dr. Goodman. Yes, that was very interesting, and interesting to see how little research we have at such a critical touch point for our patients. You know, they're all hoping to get to embryo transfer, and it's interesting to see that we haven't invested as much research. We do have a couple of questions here that I'll read out loud. And again, if any of you have questions, please put them in the Q&A box. The first question is, at my practice, the doctors have different instructions post-FET. What should I do?
So, I mean, again, you're going to have that experience versus the what's shown in the literature, and a lot of patients have put so much time, effort, and money in that they feel very strongly that they don't want to do anything. And so what we need to do is say, here's what the evidence base is. And the evidence base is that we do the transfer and that it is good for you to get up and move around. And maybe that's, we don't know why. Is that improving blood flow when we do that? Maybe when we're lying supine, the blood flow is not the same. Now, in terms of activities while we're waiting, obviously we're not going to have patients doing all kinds of crazy activities, because then they're going to do just, well, you know, they're going to say, well, I didn't get pregnant because I did such and such. Probably not. You know, I have a lot of patients where it's very warm in Florida. And so I have patients who are like, can I go to Disney after my transfer? I mean, not that day, but 2 days later. And the fact of the matter is they can walk around, but we don't want them to get dehydrated, you know? So you know, should they go on every ride? I don't know. I don't have the answer to that. And so sometimes what happens is the physicians will say, no, don't do this. And it's more because we have no guidelines for a lot of the questions, and we want to err on the side of being conservative, even if that's not necessarily necessary. Because when you think about it, you know, if yes, this is very, very valuable and very, very expensive, and very, very expensive, not just financially, but emotionally for our patients. But the fact is that when people get pregnant and an embryo goes in and they don't even know they're pregnant, you know, they might be going to Disney. They might be doing all of these things, but we're going to probably be on the conservative side simply because of the emotional part of it.
Thank you, Dr. Goodman. Next one is, what are some common reasons for canceling an FET?
For what? I'm sorry.
What are some common reasons that you might cancel a transfer cycle for a patient?
So there are several things that can lead to transfer. We mentioned about the endometrial lining, so I will touch on that in a second, but a patient who gets sick, a patient who has a high fever, you know, a patient who's been exposed and thinks that they might be coming down with COVID. You know, these are things that are to say, let's not go forward. This isn't a good idea. A patient who might have a very high estrogen level prior at their baseline. You know, obviously this is not in a natural, but in a program cycle, we may be concerned that something is going on. A lining check at the beginning that shows that even though we might have done a saline or hysteroscopy previously, maybe we did it 3 or 4 months ago, and then something came up and their transfer was delayed, and now we do a baseline and the lining looks abnormal. abnormally thick or irregular, or even with the programmed cycle or natural cycle, we're not getting the endometrial stripe thickness where we want it. Certainly on a first go, we're going to say, this isn't looking right. Maybe we're going to continue another week of medicine. Okay, we've continued. Now we're on to like our third week of medicine. We're still not getting anywhere. Let's stop, regroup, maybe change our protocol.
Thank you. Next question is, how do you counsel patients that want to transfer more than one embryo, especially if they've already tested it, they've already had testing?
Okay, so there are guidelines. So my talk today wasn't really about that, but there are absolute guidelines for patients as to whether these are PGT tested or not. I think that the standard is moving forward at this point to transfer only one embryo. Usually the recommendation for a PGT tested is going to be one embryo. Our goal is to get our patients pregnant and then to carry that pregnancy in the most healthy way possible. And so when we start to put in more than one embryo, especially for clinics that are using assisted hatching, we're going to significantly increase the risk of multiples and possibly even an embryo that splits on itself, and we could end up putting in two and ending up with 3 embryos. But even with twins, although our medicine has gotten better and better, twins are still a higher risk pregnancy than a singleton. And I explained to my patients, would you like the placenta to be divided up with your blood supply to multiple babies, or would you like it to go to one? Would you like to have a higher risk of high blood pressure during pregnancy requiring an early delivery, or preterm labor requiring an early delivery that might cause harm to your baby? So usually when we counsel our patients, we're going to be able to tell them, for a PGT tested embryo, we're not really bumping your success rates. And we're only bumping your chances of a multiple, which can significantly compromise the pregnancy, both on the maternal and fetal end. So one embryo. Now, if we've had multiple failed cycles, then that may change. And if the embryos are not PGT tested, then it's going to be based on the woman's age. So that would be a different conversation.
Thank you. The next question we have is, when do you recommend an ERA cycle or Receptiva testing for a patient?
So ERA has certainly been a little bit of a hornet's nest because the more recent studies are just not supporting it. So patients are still asking for it, which always puts the physician in a difficult position. But the more recent studies just have not supported the ERA having meaning. And so we were doing the ERA at the Reproductive Medicine Group for a period of time, and we've stepped away from that unless the patient absolutely demands it. But even there, we really guide them against it because the studies are not supporting it. Each physician has to read the literature and make their determination, but the research is not currently supporting it. In terms of Receptiva, the recommendations are going to vary. Some physicians will, the actual recommendation is 2 failed transfers, but sometimes we're going to have patients who have a very low number of embryos. And so we may, after 1 failed transfer, do the testing. It becomes a little stickier when we have patients who are wanting it even before they do a transfer. I've seen it done among physicians before transfer, but the ERA protocol is at least 1, I mean, it actually is 2, but failed transfers of a healthy embryo. Usually they're looking at PGT tested, but embryo before doing the test, it's going to again vary widely among practices. And another area that would be a very interesting study for our network, because we have so many different practices among us with already a tradition of what they do, or even individual physicians. And I think reporting on what's already going on could be extremely helpful, because just like with the ERA testing, we're kind of flounder when the patients are like, well, I want this, and we want to do our best because we want our patients, when we get that beautiful, valuable embryo, especially when there's a low number of embryos, we want to do the best we can for our patients. We all do, every one of us, whether it's even our person who's maybe not doing the clinical part, but they're drawing the blood or they're reading the patient. We all want our patients to get pregnant. We want to give them the best care possible. But again, we need to establish guidelines because too much testing can be a problem. And if we really understand what the Receptiva test is telling us, it is that there are still a significant number of people who might have tested positive, who had a transfer and got pregnant. I have plenty of patients who have previously been diagnosed with endometriosis. We do a transfer and they get pregnant. And so it is not an all or none. Yes, if we have a failed transfer and we have an abnormal Receptiva, treatment significantly improves pregnancy rates. But where is the data to say that testing everyone and never doing a transfer and just testing them outright, does that actually, then we go into a treatment, does that actually help our patient? Because we may be doing a laparoscopy, which is an invasive procedure for no medical reason, or putting someone on several months of Lupron, which is expensive and is not fun if you've ever been on Lupron, just to treat a test without necessarily demonstrating that that test was done under the right circumstances, to then say this is the outcome. So if the studies are not there to say do that Receptiva test on patients who have never even had a cycle, then we're doing a disservice to our patients if we do that without data.
Thank you, Dr. Goodman. Looks like those are all the questions that we have for today. Thank you so much for taking the time to share your knowledge with us, to help us be better educated to serve our patients. For all of you on the call, if you have any other topics that you're interested in learning more about, please let us know. Again, you will receive a recording of the session that you can share with your team members, add it to new hire training, or talk about it, discuss it at your practices as well. Again, thank you all for being here this afternoon with us, and have a wonderful rest of your day.
Thank you.
Thank you. Bye-bye.
Bye-bye.